payment system. On one hand, the payment system is encouraging the lowest cost provider, and any money that is saved by bringing the patient home out of an acute care facility is not given to home care, it's saved from the acute care side. So the hospitals may have shorter length of stays because the patients are home, but the dollars that are saved in the hospital aren't spent in home care. And that's our biggest challenge. As a provider providing these products into the home, we would love patient monitoring, which we can't afford the investment on. Home fill has been a wonderful technology that's allowed us to give the patient the independence they need without having to have them stay home every Friday to wait for their refills. In delivering product, there's obviously technology used in GPS tracking systems and netbooks that are carried on trucks, in the office, and the way you handle your billing. That's all technologically driven. But the biggest barrier is the payment system that doesn't permit you to get paid for improving the technology of the products you're providing to the patient. Things get coded one way, and that's the way they're coded, and it takes forever to get it changed. And no matter how many improvements that Invacare and other organizations make to the product, they have a challenge increasing the cost to cover their costs, and likewise do we in getting reimbursed for it. So that's my biggest frustration. And I dream of a time when oxygen can be delivered over the internet. I mean, okay, you can't do that, but why not? All right, but if you did, how's Medicare going to pay for it if they can't see a delivery truck showing up? I mean, those are things that are holding us back because everything is in silos. We're still dreaming of different ways to take care of patients in the home because that's where they want to be, and that's what we hear from our patients. They can't wait to get out of the hospital. And if we say we'll be there at 4 o'clock and we're not there till 10 after, they're on the phone because they've spent 3 days in the hospital or 8 days in the hospital. And anything we can use technologically to get them home and save that 10 minutes is a benefit to the patient. But we can't get the financial support from the payers to do it any different than we've always done. So it's going to take creativity.
Mark Sullivan, on the rehab side, as far as technology impact, how quickly, I think JB mentioned some of the new technologies. As far as timeline goes, what do you see in the future? How quickly will this impact our industry and consumers moving forward?
Well, you know, the technology does continue to improve. Things like the gyro control. You know, everybody's familiar with the iBot. Did some very interesting things for the consumers. The consumers were very excited about the potential that that product had. Absolutely no funding for it. Things like you know, the G-Track technology that we came up with. You know, we have the ability for consumers to interface with their telephone, television, communication devices all through your joystick or your head array or sip and puff, and there's no payment for that. So, you know, a lot of it, again, comes back to this archaic system of, you know, we're defined as a wheelchair. You know, first thing I'd like to do is get rid of that term wheelchair because there's nothing high-tech about the term wheelchair, and I think it tends to hold us back. But there's a tremendous amount that can be done in terms of software and communicating with my environment. Right now, wheelchair is viewed as a place to move you from A to B inside the home. They're not even, usually the payers are not even concerned about what you can do outside of the home. It's all about in the home. So we look at it a little bit differently in terms of technology, and that is being able to communicate, interface with my entire surroundings, my environment, especially when you get into folks like those with cerebral palsy that have a difficult time communicating or operating their computer. All that technology not only exists, but is waiting to explode. And it comes right back to both what JB and Joe Marx have said, which is nobody pays for it. So a lot of the R&D efforts are not as aggressive in those areas as they probably would be otherwise.
Great, thank you. All right, I'm going to get a little more specific with Dr. Landers. As far as from the hospital to the home, JB mentioned some home diagnostics and other new interesting technologies. What specifically do you see happening in the short term, and then others in the long term that will be affected by us?
I mean, in the long run, I'm convinced that the home is the future venue of care. And so, to the extent that the technology is needed to deliver care or for patient self-management of care, that technology is going to be relevant in the home. In getting it there, that's a lot of the question right now. I think that there's a lot of need for innovation in process and bringing more talent into the sector to be able to capitalize on the technological opportunities. When you think of the spectrum of things, I think we will see, specifically for those lowest mobility, most unstable population in the home, a need for mobile diagnostics, remote diagnostics, whether that be in the form of imaging, chemistry, lab work, what have you. Those are going to be relevant in order to be able to manage a high-risk population at home, and in order to substitute for hospitalization for common chronic conditions like heart disease and common infectious conditions like pneumonia and other urinary tract infections and things like that. We need mobile diagnostics in the home. I think that the information technology related to distance, remote-based providing patient encounters in the home is happening now. There are places where these things are happening faster than others. Everything from the use of mobile phones for diabetes self-management support to the use of telehealth devices for monitoring of physiological parameters associated with cardiovascular disease, to a whole range of potential monitoring of rehab. And the remote monitoring is already moving in the home and will continue in the future. And then, I think logistical support. So anything that improves how we're able to triage and to deliver care at home. We know we have a home care industry in terms of the home health perspective right now, where we have about 250,000 employees doing home visits, and right now there may be people, Medicare beneficiaries and others across the country, who are getting home visits that if it didn't happen right now, okay, it didn't happen. And then there are people who are not getting direct one-on-one care, that if they had that person to direct their care at home right now because of this situation, they might be able to avoid a hospitalization, avoid unnecessary institutionalization and loss of health function. And so any predictive modeling technologies, triage, we don't do a great job with predictive modeling and with triage right now in logistics. And so these are things that I think will make an impact. And then I don't know if I said it already, but I think that monitoring and self-management support, I think probably the ultimate vehicle for many of these things will be mobile technology. Whereas now we see some folks in the market with monitor boxes. I think that for the less acutely ill, the more chronically stable patients, those monitors will give way to potentially to mobile type of concepts. On the other hand, I think that as we try and manage a population that's more acutely ill and try to provide hospital substitution type of models, then in that population we may see a role for even more sophisticated monitoring that couldn't be done sensors and other types of things that just wouldn't be compatible with, the consumer mobile device. So, I think that there's a range there. At risk of talking too much on that.
No, that's very good. That was very good, actually. So Lou, a little twist to the question is how can we effectively work with providers to educate and help them adopt new technologies? And what are some things that we can learn on a global basis from others? And how do you see technology really, taking the forefront in the future?
I would start by saying that both the provider both providers and suppliers, manufacturers, play a part in this. And neither the provider by themselves nor the manufacturer can come up with the model to more cost-effectively service the patient. The industry, and I've been in it now 23 years, and I've visited a lot of customers. On the customer side, on the provider side, the mentality has been, and it's a very healthy mentality, it was a very healthy mentality, we do whatever it takes to take care of that client. On the manufacturing side, I've been part of that. We did a lot of things because we could. Now, reimbursement created a model. And that was the model. We did things because we could, not because they were necessarily the right things to do. Now with a lower reimbursement, that is staring us in the face, we now come to the point of doing what is the right thing to do in order to service that patient properly, and for the manufacturer to be able to supply the right product at the right cost. And that's we are on the Invacare side, on the supplier side, we are clearly looking at every product that we develop. What does this do for the provider in order for the provider to more cost effectively service the beneficiary? So the challenge we have there, of course, is what Joel said earlier. Pricing is coming down, reimbursement is coming down, so we have to figure out